Xtalks is the industry leader in connecting life science, food, healthcare, and medical device professionals. The Xtalks Life Science podcast features insightful conversations with industry experts about all things pharma, biotech, and more.
Hello and welcome to the Xtalks Life Science Podcast. I'm Ayesha Rashid, Senior Life Science Journalist at Xtalks.com. And this week, I'm very happy to introduce a special guest on the show. We have with us today Dr. Robert Perkins, who is the Vice President, U.S. Medical Affairs, Cardiovascular and Renal at Bayer, who will share some positive new Phase 3 data for Kerendia, also known as finerenone in patients with heart failure that was presented recently at this year's European Society of Cardiology Congress 2024. At Bayer, Dr. Perkins leads a team of medical directors and field team members working to advance the care of patients with cardiovascular and kidney disease. A significant current area of focus for Dr. Perkins and his team is the large-scale implementation of science programs in collaboration with healthcare systems to support guideline-directed medical therapy for cardiovascular and kidney diseases. Prior to joining Bayer, Dr. Perkins held leadership roles with Novartis and AstraZeneca. He has an MD from the University of Pittsburgh Medical School, a Master's of Public Health from Johns Hopkins University, Bloomberg School of Public Health, as well as a Bachelor of Arts in English Literature from Harvard University. To hear more about the latest trial data for Kerendia in heart failure and the landscape of heart failure research today, let's turn to Dr. Perkins now. Thank you so much for being on the show, Dr. Perkins.
Thanks, Ayesha. I appreciate the chance to talk with you.
Likewise. And Dr. Perkins, I'd like to just begin taking a step back, which I always kind of like to do, just to ask you more about how the landscape of heart failure treatment has evolved in recent years, particularly with respect to advancements in really understanding heart failure with preserved ejection fraction, that subset particularly.
Yeah, absolutely. I think if we think historically about the evolution of treatment for patients with heart failure, we think about kind of the two categories: heart failure with reduced ejection fraction, those with an LVEF less than 40%, and those with an LV ejection fraction greater than or equal to 40%, so-called HFpEF, for heart failure with preserved ejection fraction, and HFmrEF, heart failure with mildly reduced ejection fraction. And, I think that care has advanced for those with HFrEF, or reduced ejection fraction, quite dramatically in the past 20 years or so, so that today there's a fairly well-defined portfolio of therapies or pillars of care, if you will, that have really established very, strong efficacy and safety profiles, and even guidelines today talk about rapid escalation of introduction of those therapies, such that patients are cared for optimally. With HFpEF and HFmrEF, or LVEF greater than 40%, we're a little behind, and there are a number of gaps in care. We don't have that portfolio of therapies with proven safety and efficacy. We certainly have an evolving landscape where there's lots of trial activity and lots of shots on goal, shall we say. We, of course, hope that many of those are successful. But there just isn't that same level of care established yet for these patients. And, that's unfortunate. More than half of all patients with heart failure have an LV ejection fraction greater than or equal to 40%. They fall into that category of HFpEF and HFmrEF. And so, that gap is due to a lot of reasons. One of which is it's much more difficult to establish the diagnosis of HFpEF and HFmrEF than it is HFrEF. That said, though, there is some exciting things going on. We're happy to be part of that at Bayer and be contributing to that, but we're not the only players in this field, for sure.
And so, what are some of the biggest challenges facing cardiologists today when it really comes to managing heart failure in patients with mildly reduced or preserved ejection fraction, as you were talking about?
Well, I think I mentioned probably the two biggest ones already. One is just establishing the diagnosis. These patients typically have multiple comorbidities, and the somewhat and often vague symptoms they present with are difficult to link immediately to heart failure in many cases, fatigue, some shortness of breath, general malaise, those kinds of things. It makes it difficult to establish that diagnosis. And we know that there are gaps in getting to that diagnosis for many people. The other aspect is treatment once the diagnosis is established. Again, the options are fairly limited at this time in terms of what's been shown to be effective for these patients, and I think that is certainly a limiting factor. Outcomes for patients with heart failure and preserved and mildly reduced ejection fraction are certainly no better and not much different than those with heart failure and reduced ejection fraction, and those are not good. 5-year mortality rates are quite high, recurrent hospitalization. These are all gaps that I think we and others are attempting to help improve.
And I'd like to turn now to some of the latest phase 3 trial data for Bayer's investigation. Well, it's not investigational, but for Kerendia or finerenone. And I'd like to know, I know that was presented at the ESC Congress, as I mentioned in the beginning. So I'd love to hear more about that and just an overview of what the latest findings are from that.
Yeah. No, I'm excited to be able to share that. We've had an exciting late summer and fall at Bayer with finerenone. It's interesting. Those of us who work in this field, spend a lot of time and effort, weeks, months, years in many cases, and to have positive data readouts is always an exciting thing. And we're happy to have been able to share the FINE-ARTS HF trial with the community in late August at ESC. This trial was a trial of just over 6,000 patients with established heart failure and an LV ejection fraction greater than or equal to 40%. It was a randomized, double-blinded, placebo-controlled trial that followed patients for, I believe, a median of just more than 2 years for the primary outcome of recurrent or total heart failure events. Which could be hospitalization for heart failure or an urgent care for heart failure and cardiovascular death. And what we observed in the trial was a 16% relative risk reduction versus placebo favoring finerenone for that outcome. Statistically significant and obviously clinically meaningful and impactful. We're very pleased with that result. Look forward to filing our data with the FDA in the near term.
And just having, so what are the next steps for moving this project forward or the research forward in this particular setting? And also, I think related to that question as well, what are kind of some of the trends that you're seeing in heart research and clinical trials specifically for the space?
Well, there's a lot of interest currently, in this space in terms of other drug classes being explored, and that's a good thing. We welcome that. I won't comment on other companies' trials and kind of where they are because I just don't have those insights. But there is interest and there is activity and there are active phase 3 trials, which is terrific. That's what we all need to see, and we welcome that. For us with finerenone and Kerendia. We're actively exploring, pre-specified secondary analyses, tertiary analyses. We'll have a slew of post-hoc analyses in 2025. Very interesting data that we're seeing, some signals around prevention of diabetes in this population, prevention of atrial fibrillation. These are really clinically important and meaningful endpoints, and they really deserve further exploration, which we will certainly do. So we look forward to that. Obviously, filing with the FDA and hopefully seeing their consideration of our application in 2025.
And is the idea for this drug to be used as a monotherapy, or could it be combined with other drugs as well?
I think both. We certainly saw both in our phase 3 trial, which is great. We had, I believe, at baseline, 14 or 15% of the trial population was on an SGLT2 inhibitor, which is a very established drug class for HFpEF, which is great. It's actually, I believe, the only class with a 2A recommendation from the AHA. So we had some representation there, which is great. We also had a large population, obviously, that was on monotherapy or at least therapy without an SGLT2I. And interestingly, as a pre-specified analysis, we looked at those two groups, compared them, and there was no difference in efficacy across the two, which is quite reassuring. So I think, based on what we know today, it appears that finerenone can be used as monotherapy or in conjunction with an SGLT2I. I fully anticipate over years to come that HFpEF and HFmrEF will sort of play out in the way that HFrEF does. Cardiologists in general, I think, understand the typical need for these complicated diseases for kind of pillars of care. And I would imagine that we see that developing with HFpEF in the future and HFmrEF.
And in terms of its mechanism of action, how does finerenone work, and what are its targets really in addressing the pathology of HFpEF?
Yeah, it's it has high affinity for the mineralocorticoid receptor. It's a mineralocorticoid receptor antagonist. The other commonly used MRA or mineralocorticoid receptor antagonist is spironolactone. Eplerenone is another one, but it differs significantly from these what we call steroidal MRAs in its physical structure, its chemical structure, its affinity for the MR receptor, its selectivity. We don't see across trials now of nearly 20,000 patients or 19,000 plus patients, we've not seen any of the sexual side effects that you get with steroidal MRAs. We see lower rates of hyperkalemia. I think I think it's unique in that regard. It is part of the MRA class, but we consider a non-steroidal MRA quite different than a steroidal MRA, and we're starting to see that in our studies and our real world evidence.
And in terms of on the regulatory end, what are some of the challenges in this space when it comes to bringing new heart failure therapies to market? Are there any specific challenges to this particular space and to this particular class of drugs, or different classes of drugs for this indication? And so how are those industry and regulatory relationships? Because we're always seeing the FDA becoming a bit more engaged with draft guidelines and things like that. So what is the current regulatory landscape? I'd like to kind of know.
Yeah. I think it's good. I mean, it's a very, I consider this a very healthy relationship. I mean, the FDA, which is of course the agency that I have most familiarity with, they're extremely rigorous, as they should be. These are cardiovascular outcomes trials. They demand a large sample size, extensive period of study, an enormous commitment on the part of patients and practitioners that participate in these trials. And of course, a commitment from industry to resource them appropriately. So I don't really see a shortcut here. I don't think anybody's looking for a shortcut. Everyone in virtually all in all types of diseases, I think of kidney diseases because that's an active one. We're always looking for biomarkers and things that might stand in for hard clinical endpoints over the long term. But at this point in time, there really is no substitute for these rigorous outcomes trials, and they take again an enormous investment by all stakeholders. And I think the FDA appropriately asked for that, and hopefully companies will continue to deliver in that regard.
And what are some of the current trends or looking ahead innovations that you see in heart failure treatment and research, trials, just sort of the changing landscape and also with relation to addressing gaps in care for patients with this particular subclass HFpEF and also with mildly reduced ejection fraction as well. So what are kind of, I think you did mention some of the unmet needs and some of the gaps, but how can really the innovations happening in the field and where you think things are going, how can those help address them?
Yeah. I think we've talked for, decades now, probably as the community of stakeholders involved in trials about, more targeted therapies, more selective, or more highly selective approach to patient populations. These are things that are still aspirational to some degree. I think we're getting closer to that, but we all look for a day in the future when we know that a specific therapy is going to work and be safe for every patient that takes it. And I think we're in a far better place than we used to be, but we still have work to do there, no question about it. The other challenge, and it exists for all of us, is ensuring that our trials, everyone's trials, really represent the populations suffering with the disease. And I think we talked about this, Ayesha, last time we spoke. Bayer has made some efforts in that regard, and we've made some advances in that regard. And we're doing some interesting things actually with our Moonraker program around that as well. But that remains, a challenge as well. I think is to ensure that we're studying the right patients, the patients that are most need therapies and hopefully will most benefit from them.
And looking ahead, in your opinion, what do you think will be sort of the next big breakthroughs? I kind of hate to use that cliched word, but in cardiovascular research in general, it's a very dynamic field. And so what do you see to be the next innovations or the next breakthroughs and how they might shape the future of the field?
Well, and it may not be a lot different than a lot of other very morbid chronic conditions like heart failure, but I would love to live in a world in my lifetime, maybe not realistic, but one in which we're really focused more on prevention, whether that involves drug therapy or other changes like lifestyle changes. But I would love to live in a world of prevention rather than kind of the reactive mode, which we're all in, right? I mean, we identify a disease and then we manage it. It never alleviates all suffering. And we know that it's better than the alternative, but I think, we need to think ambitiously about a world in which we're preventing disease more commonly than we are today.
Mm-hmm. Yeah, I love that. Definitely. And I think people kind of maybe underestimate or overlook the fact that a lot of companies, like a big company like Bayer, that there are those aspects that researchers and leaders like yourself are indeed exploring and thinking about. So it's really great to hear that, indeed. And is there anything else coming up from Bayer's cardiovascular pipeline that we can look forward to and hopefully speak to you about in the next couple of months or in the next year or so in its pipeline?
I would love to come back and talk with you, Ayesha, about our Moonraker program, which I think we briefly touched on last time. But it's a program unto itself. Actually, the Ferosys HF trial is technically part of that, but there are 3 additional trials that I think are really interesting and fascinating. They all involve finerenone. They all involve different questions about how to best manage patients with heart failure. Actually across the spectrum, in this case, of reduced, mildly reduced, and preserved ejection fraction. So that's certainly one top of mind for us, top of radar for us. And we certainly have an extensive pipeline that I can't talk too much about now, but Bayer being Bayer with its legacy and history is always actively investigating new therapies with a strong commitment to cardiovascular medicine and disease.
Indeed, quite the legacy at Bayer, and we look forward to learning more in the coming months and years, and to see what other projects, other research, and other developments that you'll be leading. So, Dr. Perkins, I want to thank you so much for your time once again, and it was a pleasure having you on the show once again.
Thanks, Ayesha. I enjoyed it.
All right, that's the end of this episode of the Xtalks Life Science Podcast. If you liked today's show, don't forget to rate, review, and subscribe. Thank you, everyone, and we will see you next week. Bye for now.
To join the Xtalks community, visit xtalks.com and register for exclusive access to curated content like live webinars, news articles, and educational videos. The views and opinions expressed in this podcast are those of the speakers sharing them and should not be taken as professional advice, nor do they necessarily reflect the policy or position of Honeycomb Worldwide. For further information, email us at podcast@xtalks.com.